Thank you for joining us. I'd like to welcome everyone to the STS 2025 webinar series. Today's webinar is titled Updates to the Treatment Landscape in Non-Small Cell Lung Cancer, Adjuvant and Neoadjuvant, supported by AstraZeneca. Please note this webinar is being recorded and will be available on the STS website and YouTube channel. At this time, I'm pleased to introduce our moderator for this evening, Dr. Shrager. Let me turn it over to you.
Good evening, surgeons, medical oncologists out there, or good afternoon from California. My name is Joe Shrager. I'm going to moderate tonight. I'm the Chief of Thoracic Surgery at Stanford. And we are going to focus on the latest developments in the rapidly changing world of multimodality therapy for resectable lung cancer. Everyone who's here probably knows that there's been essentially a sea change over the past several years in how we're approaching these patients with locally advanced lung cancer. We used to have pretty simple algorithms, for example, less than N2, resect. They get adjuvant chemo only if the nodes are positive, and that was about all you needed to know. And for 3A, it was basically induction chemo if you thought it was resectable, and then operate. Now this has become a whole complex of difficult decisions with options that are different for every subtype of tumor. And even in patients as early as stage 2A, we have to think about pre-op versus post-op, immunotherapy versus targeted therapies. And the surgeon is at the center of these decisions because we're often the first person to see the patient. Even the definition of what's resectable is in evolution and probably expanding. So we'll try to address the most recent info on these topics, focus especially on what's emerged in the last year or so, but obviously you sort of need to form the foundation, so we'll go back further than that. We have two outstanding speakers, Joel Neal, who's a medical oncologist here at Stanford, Kiran Lagisetty, who's a thoracic surgeon at the University of Michigan. We'll try to keep the talks to about 15 minutes and leave plenty of time for discussion and questions at the end, which is always the most interesting part. There's a Q&A place where you can submit questions, which we will get to at the end. So the first speaker is going to be Dr. Joel Neal. Joel is a prominent medical oncologist focused on thoracic oncology and clinical trials and translational research as well. He's a professor of medicine here at Stanford. He co-directs with me what we call our clinical care program in thoracic oncology. He also directs our clinical research group, which is the clinical trials group, both for our group and for, in fact, our entire cancer center. So Joel, let's hear the medical oncology point of view.
Thank you, Joe. And it's a pleasure to be here with the STS. I know I've co-written position papers and statements with all of you, and hopefully we can get the message out about the exciting developments in medical oncology and how we can work together in curing more cancers. First, I just want to reflect, what was it, 5-6 years ago, that basically my talk would have been done in about one slide. I would have shown the LACE meta-analysis, and we would have said there's a 4 to 5% overall survival benefit of chemotherapy, and then we're done, right? Move on. We've tried a lot of things, and those haven't worked. But thanks to immunotherapy, targeted therapies, and hopefully novel therapies, we've actually moved the needle quite a bit in the adjuvant and neoadjuvant treatment of non-small cell lung cancer over the last few years, to the point where it's hard to almost keep track of all the trials, but we'll go through them right now. Here are my declarations of interest. So first of all, I want to point out we're going to talk about preoperative or neoadjuvant immune checkpoint inhibitor, or ICI. We're going to talk about postoperative or adjuvant immune checkpoint inhibitors. Then we're going to talk about perioperative trials, where patients got them before surgery and also continued some sort of therapy after surgery. And then finally, we'll end up today with the targeted therapies. We have a couple of strong trials in the adjuvant setting after surgery and then also neoadjuvant. So the questions are, what do these approaches add? Which is the best for an individualized patient? And what are the variables and, medical conditions that we need to think about beforehand? So here's one way of thinking about all the trials that we have for immune checkpoint inhibitors. When we look at the adjuvant setting, so post-operatively, we have monotherapy trials for the most part because patients have gotten chemotherapy, surgery and chemotherapy as standard of care before they go on to the trials. Then we think about the neoadjuvant studies where patients are hopefully surgically resectable, but then we're giving treatment ahead of time, oftentimes with immunotherapy or chemo plus immunotherapy. And then there are the perioperative studies where we've given often chemotherapy plus immunotherapy beforehand with maintenance treatment that's almost exclusively immunotherapy afterward because it's well tolerated. So let's start off with neoadjuvant treatment. And neoadjuvant alone treatment has a lot of advantages. So I know when I was an oncology fellow, we would talk about bladder cancer and breast cancer and say, when do we do surgery ahead of time? When do we go straight to surgery? When do we give treatment afterward? And I was wondering why, with my focus in lung cancer, were we almost exclusively giving treatment after surgery was done? Well, our patients may have comorbidities. We don't want to beat them up with tough chemotherapy. Chemos have gotten easier over the years, and immunotherapies have been shown to be effective. So, what's the advantage of neoadjuvant? Well, in a healthier person, they may have a healthier immune system. We can actually also see whether the treatment worked. So pathology can show us whether there was a responsive treatment, whether we have nodal downstaging, and whether there are other advantages to giving neoadjuvant therapy. So, we like to know whether our treatment works. And in the adjuvant setting, nobody really knows, except for maybe ctDNA testing. So one of the standards of care right now is based on the Checkmate A16 trial. This was nivolumab plus chemotherapy. Nivolumab's a checkpoint inhibitor. Got surgery within 6 weeks of treatment, so only 3 cycles beforehand, and then optional adjuvant chemotherapy, but no more immunotherapy. Excluded PD-L1 negative patients, or sorry, excluded EGFR and ALK patients, and most of the patients had positive PD-L1. So we just saw the 5-year analysis. Today we're trying to do updates. So at ASCO 2025, a couple of months ago, we saw the 5-year analysis, and here for event-free survival is an almost 15% benefit in event-free survival when we look at that 5-year time point maintained over the curves. When we look at exploratory analyses, we've learned over and over again that pathologic complete response is a strong surrogate for doing well, right? If the neoadjuvant treatment worked well, then probably patients are going to do better. So we see here any patients with past CR, whether they got chemo or nivolumab plus chemotherapy, did better. But there were a lot more patients with past CR in the nivolumab plus chemotherapy arm. When we look at the overall survival presented a few months ago, here's a 10% absolute survival difference, right? I started off by saying, remember that 4 to 5% that we saw from the LACE meta-analysis from chemotherapy alone? So now here, for an unselected group of patients by PD-L1, excluding EGFR ALK, 10% absolute survival difference. Not bad at 5 years. And then by PD-L1 expression, it looks like there's definitely a stronger benefit in PD-L1 positive than PD-L1 negative. But currently, this regimen, at least in the US, is approved regardless of PD-L1 status. So the key points, PD-L1 is important. This was only 3 cycles of treatment. I've talked to my international colleagues outside of the US, and a lot of them say that this is really a favored neoadjuvant regimen because it is very cost effective. We're only giving 3 doses of all the treatments, and it's very effective overall, and there's an overall survival benefit reported. More benefit, of course, with higher stage. So what about adjuvant immune checkpoint inhibitor? This is more classic of what we did in lung cancer. For example, after chemotherapy, after surgery, after chemo, giving immune checkpoint inhibitor versus best supportive care, basically observation. And what we saw in this trial run by my colleague Heather Wakely, we saw that there was a overall survival benefit over there on the right-hand side, overall survival benefit in the PD-L1 positive, stage 2 to 3A population, but actually in this trial, not the overall population. So currently, This is currently approved, strongest benefit in PD-L1 50% population, but currently approved just for PD-L1 positive disease. So if a patient gets surgery, chemotherapy, and is looking for more options, PD-L1 positive tumor, EGFR ALK negative, this may be an appropriate treatment option. There's another adjuvant regimen that's also approved, adjuvant pembrolizumab. This is based on a smaller study. And here, the only nuance from this study in that bottom to the right red box is that the PD-L1 did not strongly predict benefit quite as much as other studies, with the strongest benefit in the middle PD-L1 rather than the high PD-L1. This study, incidentally, did enroll EGFR mutant patients, and strangely seemed to be a little bit more benefit in pembrolizumab also for them, but we'll get back to that because there are better options. So in adjuvant immune checkpoint inhibitor, the driver mutation status is known because we tested ahead of time. PD-L1 outcomes are a bit mixed, and past CR is a little less relevant because, of course, patients just went straight to surgery. What about perioperative? And now we have 3 perioperative regimens. So one is perioperative durvalumab from the AEGEAN study. One is the Keynote 671 of pembrolizumab, and then the Checkmate 77T of nivolumab. In the AEGEAN study, we had patients randomized to durvalumab plus chemotherapy versus placebo plus chemotherapy for 4 cycles total, then went to surgery, then either got durvalumab if they were assigned to the durva arm or placebo. So in the study, this was positive for event-free survival in the upper right. It was also positive for in many different other subgroups, looking at the primary endpoint of event-free survival with neoadjuvant. Left side, AEGEAN, durvalumab, positive for event-free survival. Upper right, pembrolizumab, positive for event-free survival. Bottom right, Checkmate 77T, nivolumab, positive for event-free survival. So all of these 3 led to FDA approvals based on this. In the pembrolizumab trial, overall survival looks like it's trending to positivity with, again, about a 10% overall survival difference when we look out there at 4 years. And then overall survival in key subgroups, definitely more benefit in PD-L1 positive tumors. Again, sort of strangely, maybe a trend to benefit in EGFR positives, but I don't think that's real. And then most recently at the World Conference in Lung Cancer that we just went to in Barcelona a month ago, tislelizumab, which is an immunotherapy approved only in Asia, had a positive benefit both in squamous and non-squamous histology for overall survival on its final analysis. And again, here we're seeing almost exactly a 10% overall survival benefit in this group at 5 years. So what's important to point out is in neoadjuvant trials, as well as just the neoadjuvant, like the Checkmate study, up to 20% of patients don't get surgery at all. And I think Dr. Lagisetty is going to focus on this in his talk. So for perioperative immune checkpoint inhibitor, there are 5 trials now with event-free survival benefit. One of these has an overall survival proven benefit, and the others are still maturing, including the AEGEAN study of durvalumab. PD-L1 status is very important. Driver mutations are excluded, or kind of strange low numbers that's hard to tell. But the biggest question is, if we give preoperative therapy and patients do very well, do we really need a year more of therapy after that, or can we get rid of it? And that's the focus for a lot of cooperative group studies right now. So there's still a lot of questions. Should everybody get neoadjuvant therapy, or are there patients who should still go to surgery first? Because we have lots of good adjuvant options that are approved that we can offer to them. What does that adjuvant component add after we've given neoadjuvant immunotherapy? I've been known to say maybe 1 dose of immunotherapy is all that some patients need to get all of their response. But it's clear that other patients maybe need continuation immunotherapy to continue to suppress the immune systems, suppress the tumor, and help the immune system fight it. What's the optimal duration? I don't think we really know. Some of these studies had 2 to 4 cycles, some had 3, some had 4. And then I think we're entering an era that we don't have time to go into today of molecular residual disease, or MRD, to identify those patients that are early progressors just by DNA signatures of the cancer still being there after surgery, versus those that seem to have complete clearance and are probably cured. What about driver mutations? So out of the now 12 targets that we have in non-small cell lung cancer that we have targeted therapies for, 2 of them have adjuvant data, and we're still waiting for adjuvant data on a lot of the rest of them. So for EGFR mutant lung cancer and ALK-rearranged cancer, we have solid adjuvant therapies that need to be used instead of immunotherapy for these patient populations. Immunotherapy is generally believed to be very ineffective in tumors that are less smoking associated. So it's important to know PD-L1 status, as well as EGFR status, as well as ALK status, and I would argue NGS sequencing, complete sequencing of the tumor, either preoperatively or from the surgical specimen, is critical on all of these patients for our adjuvant decision-making. So here's the ADAURA study. This is one of the first studies to show an overall survival benefit from adjuvant treatment in EGFR mutant lung cancer, actually the only study. You know, what's interesting, though, is the disease-free survival. So this was patients who got surgery, chemotherapy at investigator discretion, so optional chemotherapy, and then got osimertinib for 3 years versus placebo. And OC is our current first-line standard of care in non-small cell lung cancer in the stage 4 setting, also with or without chemotherapy. So given osimertinib for 3 years, you can see in the upper right that around that 36-month time point is the biggest difference between the curves. And then they start to get closer as patients start to recur as we stop the drug. So this is probably acting more suppressively rather than curatively. It's more cytostatic. However, despite that, we do see an overall survival benefit lasting at 4 years and 5 years across all stages of disease down to 3.1 centimeter tumors. So the current standard of care is to give osimertinib for 3 years after surgical resection of early stage non-small cell lung cancer. And currently we're investigating studies to do that longer, 5 years, or maybe for MRD positive patients even longer than that. At ASCO this year, a couple of months ago, there was the Neoadjuvant study. ADAURA is kind of the name for all the osimertinib studies. So the Neoadjuvant AURA study, in which patients got before surgery either osimertinib, TKI, osimertinib plus chemo, because as I said, that's effective in the stage 4 setting, or just chemotherapy alone, went to surgery, and we've started to see some data from this so far. I thought what was most striking, so first of all, the majority of patients went to surgery here. So, 90% or more went to surgery. So these therapies are not preventing patients from going to surgery. In fact, even more maybe than get neoadjuvant chemoimmunotherapy, but maybe it's a healthier population. What I thought was most striking was this graph over on the right, where the complete response rate from chemotherapy was only 2%. We actually thought we were going to do better with chemotherapy than that. But both osimertinib plus chemotherapy and osimertinib monotherapy both gave much higher major pathological response rates, around 25%, where it was almost not seen with chemotherapy alone. With event-free survival analysis, it again looked like the osimertinib plus chemotherapy, the dark line on the very top, had the strongest benefit, and then at least early on, the osimertinib monotherapy did well. I think we need longer follow-up here, since we're relatively short follow-up, only 15% maturity right now. But I think this is showing us that if a patient needs neoadjuvant chemotherapy before surgery, and we know they have EGFR mutation, or we suspect they do, probably the right treatment is start with chemotherapy, add the osimertinib if we find the EGFR mutation. Don't give immunotherapy to this patient population. For ALK-positive non-small cell lung cancer, this is the ALINA study. The major difference between this and the osimertinib study was nobody got chemotherapy, but still we see a very strong disease-free survival benefit out there at 2 years, 3 years, 4 years from the treatment of adjuvant alectinib after surgery. So this is currently a standard of care for 2 years after surgery. I'll also point out we at Stanford and elsewhere conducted the ECOG Akron E4512 study, which was ALK crizotinib in early stage non-small cell lung cancer, the first drug believed to be very effective and targeted in ALK positive lung cancer. And this study was negative for disease-free survival and overall survival. We don't see much difference between those curves either on the left or the right. So maybe there is something about having a much more potent, selective, tolerable TKI when we're doing these adjuvant studies. And, historically, we ran adjuvant erlotinib studies also, which was a much tougher drug. So I think, we have to wonder whether these are curative or cytostatic therapies. And we do see these disease-free survival curves coming together, both for Alina and for Adora. So the question remains, is 2 years or 3 years enough, or do we need to continue beyond that using tools to select patients? Because, of course, we don't want to treat patients indefinitely who might be cured. These are my conclusions for today. First of all, neoadjuvant therapy is a standard of care, but patients who should go straight to surgery may do that. And we can always consider what are the best adjuvant therapies afterward, either chemotherapy, immunotherapy, or TKIs for ALK and EGFR. We have to stage and we have to test for all of these mutations to really understand what the patient population is. And it's worth involving medical oncologists, surgeons, and others in multidisciplinary conferences, like the one that we participate in every week, Dr. Shrager. And involving these multidisciplinary discussions to figure out what the best way to go is. For stage 3, I think, neoadjuvant has a very strong role. And we could talk about which patients with stage 3 should have surgery. For stage 1 and 2, I think going straight to surgery and then considering adjuvant options is perfectly appropriate. We have to think about biomarkers. We have to think about benefits of adjuvant after neoadjuvant therapy and not over-treating patients. MRD, looking for circulating tumor DNA, I think is going to be evolving. For other targetable alterations beyond EGFR and ALK, we're certainly tempted to say what is the role, but the TKIs may be less potent or less well tolerated. So I'm hesitant to use those personally. And then the biggest question for Dr. Lagisetty next is who should just go to surgery first? So exciting times and much more to cover than there would have been 5 years ago. Thank you.
For sure. That's a great summary. I don't think you'll see a more succinct summary of all the important data. That's a lot to cover. So thank you, Joel. Kiran, maybe a little more practical information. I'm not going to say that Joel's stuff isn't practical, but a little more day-to-day for the surgeon. How does this affect the decisions that we have to make, when a patient's sitting in front of you and when you're trying to decide what the best way to go is for a particular patient? So Kiran from University of Michigan, what are your thoughts?
Yeah, thank you. Thank you for the opportunity to discuss this topic this afternoon, even depending on where you are. So my name is Kiran H. I'm a thoracic surgeon at the University of Michigan. I'm going to discuss some of the surgical decision making in this new immunotherapy era. Here are some of my disclosures. None of these disclosures are relevant to the talk that I'm about to give. So here are some of the learning objectives that I wanted to highlight for this talk. We're going to discuss which tumors are resectable and have indications for a neoadjuvant therapy, and some of the controversies around determining resectability. We'll discuss how neoadjuvant therapy, specifically chemoimmuno, has impacted how we perform lung cancer resections. And then lastly, we'll discuss some of the postoperative considerations for patients who are undergoing resections after undergoing neoadjuvant therapy. So resectability. During this first section, I'm going to discuss some of the current indications for resectability and some of the controversy surrounding which patients are resectable. With the studies presented by Dr. Neal, we're witnessing a significant change in treatment paradigms when it comes to managing operable lung cancer. The current guidelines exhibit significant variation in resectability criteria, and the recently completed and ongoing studies lack mention of resectability determination in their inclusion criteria. And given the lack of consensus, it makes identifying patients who may be candidates for these therapies very difficult. Locally advanced lung cancers typically refer to tumors that are clinically stage 2 or 3. However, you can see from the most recent 9th edition staging guidelines, this represents a large swath of a variety of clinical TNN stages. Therefore, all stage 2 and 3 tumors are not necessarily all biologically the same. And because these stages are made up of so many different TNM subsets, this is what really leads to a lot of the difficulty around determining what is resectable disease. So a couple of different groups have tried to determine what is resectable. And here are two recent consensus guidelines that were put out this year around this question of what is a resectable tumor. The panel on the left side was the results of the European Organization for Research and Treatment of Cancer, specifically the lung cancer group. They created a Delphi panel and published these results earlier this year. The group administered a survey to practicing thoracic surgeons, radiation oncologists, medical oncologists, and pulmonologists. And each respondent would answer whether they thought each particular TNM match was either resectable, unresectable, or maybe. And if 75% of patients or people were in agreement, that was the threshold that was used to base a recommendation. And this group consisted of 558 respondents, and they were only able to agree on one TNM subset for resectability, which was a T3N1. You can see there was much more consensus around what the various groups thought were unresectable. However, most of the subsets of these TNM stages were either considered potentially resectable or no agreement could be reached. Similarly, the Society for Thoracic Surgeons put out a consensus guidelines of which TNM subsets their expert group considered resectable. The two groups had some overlapping guideline recommendations. However, there still remained lots of areas of differing opinions. Both groups consider T3N1 disease resectable. However, there's a lot of variability in subgroups in patients with single station N2 disease and patients with N2 with bulky disease. So these two studies, written by experts in their field, demonstrate the lack of consensus around resectability in these various subsets. So who's resectable? All that, and the question is, it depends. So patients with locally advanced lung cancer should all be discussed in a multidisciplinary setting with significant surgeon involvement. Dr. Neal was very wise to suggest this as well. In today's age, locally advanced lung cancers need thorough diagnostic workup, staging, molecular testing, and all of these in combination are really what's going to allow you to provide the best treatment recommendations for each of these patients. So for the surgeons, when you're thinking about resectability in these TNM subsets, I think there's a few things that you have to consider and take into consideration. One is the ability to achieve an R0 resection. Why? Because we know from existing data the best long-term outcomes are from patients who are able to undergo an R0 resections. I think this goes along hand in hand with what Dr. Neal was presenting with patients who are able to achieve a pathologic complete response. When you're able to do that, these patients have the best long-term survival. And I think similarly, when you're able to achieve a R0 resection, these patients tend to do better than others. When we're thinking about resectable patients, we want to be able to perform these resections with acceptable morbidity. We've gotten to be really good at doing lung cancer resections, and morbidity rates from lung cancer operations are the lowest they've ever been. And every effort has to be made to make sure that these patients are going to go with safe operation, especially since adjuvant treatment options are available for patients, and we want to be able to take patients after resection and allow them to go on to receive adjuvant therapy if needed. And then you also want to take biology into consideration. So this, I take to mean you can't use these neoadjuvant therapies as a way to convert non-surgical patients to a surgical patient. This is shown not to be an effective treatment approach, and I think we have to caution ourselves on trying this this approach. So how does neoadjuvant chemoimmunotherapy impact surgical resections? With more locally advanced patients undergoing neoadjuvant therapy, the impact on subsequent surgical resection is an area of interest. We've all heard anecdotal cases of increased difficulty with the inflammatory response of lymph nodes, and I spent the next few minutes discussing some of these intraoperative considerations for patients undergoing neoadjuvant therapy. So, as Dr. Neal was highlighting, about 15 to 20% of patients don't make it to surgery. And surgical delays have to be anticipated in these patients, especially when patients experience adverse events, especially specifically pneumonitis. Oftentimes with this complications, it can be associated with steroid administration, and you have to be able to time surgical resection in an appropriate way, especially when dealing with that complication. The aforementioned neoadjuvant trials have also demonstrated disease progression can occur in about 10% of patients, which is not trivial. And this can, one, render patients non-surgical, or secondly, make intended surgical resections more difficult. So the most difficult aspect of neoadjuvant therapies to quantify is the inherent inflammatory reaction which occurs after the therapy. Sometimes these effects can be minimal. However, many patients, inflammation and fibrosis can lead to increased surgical difficulty. So some of the results that we've seen in some of the neoadjuvant trials here in the Checkmate 816 trial, we saw about 15 to 20% patients didn't make it to a surgical resection. Those who did make it to a surgical resection, about 13 to 25% will have delayed care, and with an average delay about 2 weeks. In most of all of these trials, you'll see that more than half the patients underwent a thoracotomy with an approximate 10 to 20% conversion of minimally invasive to open. These rates of thoracotomy have been pretty consistent across all the different trials that have been reported on. And most of the early trial data have demonstrated planned thoracotomy rates around 40 to 50%. In the Checkmate 816 trial, when you look at duration of operation, blood loss, they were pretty similar across the different treatment arms, and the average length of stay for these patients was about 10 days, which is actually not a trivial amount of time for lobectomy, considering patients who undergo lobectomy for early stage lung cancer typically will have a inpatient hospital stay about 3 days. So when we compare surgical outcomes across trials, again, the amount of patients who don't make it to surgeries hovers around 20% across all of these different neoadjuvant studies. These studies show relatively low 90-day mortality and high rates of R0 resections. You can see that the R0 resection rates across these trials are anywhere from 70 to 96%. Recent single center studies have consistently shown R0 resection rates can be achieved with about 90+% of the time. And then you can see that when you're thinking about caring for these patients, about 20 to 60% of patients can have grade 3 or 4 adverse reactions from their neoadjuvant therapy. And you have to take these into considerations, because not only can it complicate your surgical resection, but when you're dealing with complications such as pneumonitis, this can have postoperative implications as well. So with this increase in thoracotomies, is there a role for minimally invasive surgery? Most of the surgeons will say, like, when you see patients, one of the first questions they'll ask you is, are you going to use a robot? Or is this going to be a big incision? And although a lot of the initial trial data did show a high rate of thoracotomy, and I think with more centers reporting out their individual outcomes, the short answer is yes. Like, there is still a role for minimally invasive surgeries. In this study that I'm showing here, this was data from 207 patients across 5 centers in the United States and Germany, which demonstrated 79.2% of patients were able to undergo a minimally invasive resection, which is most commonly in lobectomy, either by a robotic or VATS approach. Open procedures were still utilized more oftentimes when you're doing more complicated resections, like a bilobectomy or a pneumonectomy. The biggest benefits of the minimally invasive approaches in this study was that it had very low mortality, faster recovery, low conversion rates. Again, all things that help patients heal from these operations, as well as enable them to receive adjuvant therapy if needed afterwards. This data has been reproduced in multiple subsequent trials as well. And then when we think about minimally invasive approaches, we have to think about, well, when do we convert to open, and what are some of the considerations that we need to think about when we convert to open operations, given the technical complexity. Here's a study from China, from Zhang et al., who reviewed 131 patients who received treatment with neoadjuvant chemoimmuno. There was 42 conversions from minimally invasive to open in these groups. And the primary reason for conversion was primary tumor invasion. Other reasons for conversion included adhesions or fibrosis, calcified lymph nodes, pleural adhesions, and bleeding. So this takes us to our next issue of what to do with the nodes, because anybody who's operating on these patients who's received neoadjuvant chemoimmuno know that there's some inherent nodal inflammation that occurs. Some people reported some of the reasons for the high thoracotomy rate is because of this anticipated nodal reaction. The immunotherapy will oftentimes result in nodal inflammation, and they can make these nodes very adherent to vascular structures such as the pulmonary artery. In this study from MD Anderson, they evaluated 124 patients who underwent neoadjuvant therapy. Now, this wasn't limited to only immunotherapy, just anybody who received any kind of neoadjuvant therapy. But it does offer some insight into some of the surgical challenges of nodal disease for patients undergoing neoadjuvant therapy. In this study, it demonstrated that in patients with N1 disease, about 15% had nodes that couldn't be removed off the PA. 20% had nodes requiring change in approach to vasculature, such as having to obtain proximal or intrapericardial control of the pulmonary artery. And about 5% had to change in the extent of surgery, with 18% of patients needing arterioplasty or arterial sleeve resection. So when we think about surgical considerations, the emerging literature from trial data and real-world experiences demonstrate that neoadjuvant therapy does result in more technically difficult lung resections. Minimally invasive approaches can and should be utilized. However, surgeons should be ready for technically challenging operations, which require open or more advanced resection techniques such as sleeve lobectomies, arterioplasty, bilobectomies. Experience is very critical for good surgical outcomes, and knowing when to convert is really important in these cases. Surgeons should know that these fibrotic tissues are very fragile. Dissection has to be meticulous and careful. We had to prioritize patient fitness, given the adverse events that can sometimes be associated with neoadjuvant therapy. And this kind of highlights the last topic of discussion is the postoperative considerations for these patients. I'm going to briefly discuss some of the postoperative complications associated with neoadjuvant chemoimmunotherapy who are undergoing lung cancer resection. When we think about some of these postoperative complications, they occur with any lung cancer resections, but patients who are undergoing neoadjuvant chemoimmuno are particularly prone to adverse events, considering some may experience some physical decline following immunotherapy administration. So therefore, pre-op optimization is really key to successful outcomes postoperatively. Immunotherapy can lead to side effects as pneumonitis, adrenal insufficiency, thyroid dysfunction, and these side effects have the potential to increase risks of postoperative complications. Pneumonitis in particular can mimic as an infection, and trying to figure out if patients suffering from pneumonitis or pneumonia can be a difficult diagnostic dilemma in the treatment of these postoperative patients. Currently, there's pretty limited data around the postoperative complications. Most of the trial data was focused on conversion rates, blood loss, operative times, length of stay, but recent institutional and real-world experience has shown that complication rates have ranged anywhere from about 15 to 40%. However, we're seeing more institutional data, center-level data that that is having more experience with these kind of resections, and we're finding that complication rates are pretty similar to complications rates in the pre-neoadjuvant setting. This is a summary of adverse outcomes reported in several of the recent clinical trials, which shows the mean described complications were pneumonia. Other less common complications included things like bronchial fistula, prolonged air leak. The real difficulty in determining rates of postoperative complications was really secondary to the heterogeneity of these studies, given the side effect profiles of different therapies, patient adverse events, and surgical expertise at the different centers. So this is another table taken from that the study from China that I mentioned earlier by Zhang et al. They reported a 21% 30-day complication rate. The most common complication they found in their cohort of patients were pneumonia followed by prolonged air leak. And these are mostly VATS or thoracotomy groups. In the thoracotomy groups, the more common complications included pneumonia, respiratory failure, and arrhythmias. So overall, the complication rates from these studies have been pretty similar to observed rates for patients undergoing lung resections who didn't get neoadjuvant therapy, although there's some unique complications that surgeons should be aware of. And even though that these happen, it hasn't really shown to lead to worse surgical outcomes in these patients. So really, the points that I wanted to emphasize with this talk is that emerging treatment options for locally advanced lung cancer have changed our conventional treatment paradigms. With neoadjuvant chemoimmuno strategies, there's a potential increase in technical difficulty of lung resections. However, recent trial data really shows that there are equivalent outcomes in patients, whether you see chemotherapy or chemo IO. This underscores the need to carefully select patients for resection in a multidisciplinary fashion with input from experienced surgeons. Surgical resection approach should be based on technical skill level and may require open operations. In addition, surgeons should be comfortable with advanced resection techniques when taking on these patients. And then lastly, the surgeon should be aware of unique postoperative complications, which may arise from immune-related toxicities, especially around the management of pneumonitis. Thank you.
Thank you, Dr. Lagisetty. A reminder to the audience that you can put questions on the Q&A, but I will offer some questions to our very knowledgeable speakers. The first thing I just want to point out, this may seem obvious, but it took me a while to kind of arrive at this in my own mind. Yes, maybe 20% of patients don't make it to surgery, but those patients were included in the survival data, right? So it's an intention to treat study, so they're all included. So if the survival rate is 10% greater, that includes the bad fact that some of them don't make it to surgery. Still, the survival is much greater. So that's, I think, an important point for surgeons to keep in mind. Yes, we'd like to operate on everybody who we see and plan for surgery, but if their survival is better after all of this, that's probably what we all care about, the most. How about a couple quick cases? See what each of you think about these cases. A relatively healthy person with a 4.2 centimeter clinical N0 on CT and PET, central right upper lobe tumor. PD-L1, 3%. It's a person who has been a cigarette smoker in the past. Pretty good pulmonary function. Would you give induction, Dr. Neal? Would you recommend induction? Does he need an EBUS first to decide about induction? Should he go straight to surgery?
Well, despite the smoking history, I still want EGFR-ALK next-gen sequencing if possible. Yeah, I'm probably not going to give neoadjuvant immunotherapy to somebody who might have had a smoking history, but I'm not sure what their EGFR-ALK status is.
Everything's negative except for the PD-L1 and a P53 mutation.
All right. Well, with 3% PD-L1, I'm happy to give neoadjuvant. I guess I'd defer to Dr. Lagisetty to look at the scans at tumor board, decide what the resectability is up front.
So you're not pushing hard for a 4.2 centimeter. So that's a stage 2A N0 tumor. You're not pushing hard for induction?
Depends on the risk of surgery, I would say.
Okay. Kiran, what do you think about a case like that?
Yeah, I think complete staging. I would make sure I got adequate EBUS with nodal sampling. If the nodes are all negative, and I think it's surgically resectable for T2 N0, I'd take it out first.
Okay, but now those patients were included in most of these trials.
Yeah, so you bring up a
good. Did the subset analysis show that they're not really getting that 10% benefit?
Yeah, because when you break down most of these trials, especially Checkmate 816, you see that the subgroup analysis showed that the group that benefited the most is the stage 3A patients. I think it's very clear that those patients do have benefit for chemoimmuno. But when you talk about stage 2 patients, that's when you start getting a little bit more mixed results. I don't think the subgroup analysis demonstrated statistical significance in that subgroup specifically.
Okay. What
I mean,
about
for this
what if-
patient, I would definitely give chemotherapy and I would definitely give immunotherapy afterward. Like both of those are data driven, right?
I totally agree with
And
that.
I'll point out that there's an ongoing cooperative group study right now, which is called the ASCO study, ACCIO. Yes, that is the Harry Potter's like summon spell. So the ASCO study, which is run by the NCI, is actually testing concurrent pembrolizumab with chemotherapy versus sequential. So trying to figure out whether we can actually give it all together like we do in stage 4.
in the adjuvant setting?
In the adjuvant setting.
Yeah.
So this patient would be appropriate for adjuvant, but I'm fine doing that after surgery. And with the PD-L1 positive, atezolizumab would be approved too in this setting.
What if that patient's PD-L1 was greater than 50%? Does that push you to give it neoadjuvant?
No, 0 or 1 or greater, is
Oh.
really where it is. So
Okay.
positive 1% versus negative. In the negative setting, actually atezolizumab is not FDA approved. And the one approved drug would be pembrolizumab, but pembrolizumab has less strong data for the overall survival benefit right now.
Okay.
So, for the PD-L1 0, they don't seem to benefit nearly as much from adjuvant immunotherapy, and they have equal risk of toxicity.
Do you think there's something about the tumor being in the lymph nodes that makes the response better, or is it just that those patients are worse, so they benefit more from getting a better treatment early?
I feel like we have an immunobiologist on the call instead of just somebody who has a PhD in immunology from 20 years ago.
Yeah, I mean that's $1 million question, right? Because we don't know the answer to that. It's a theoretical opinion. We think that if you have tumor antigens that are present, you have better efficacy. But it also there's been plenty of targeted drugs that have shown that you can still have cancer even if you're able to target specific proteins, and you can also treat patients. There's also the patients who have low PD-L1 scores or 0, some who are sometimes responders, right? So I think we just don't know. I think that's a big part of all of this. We just don't know.
I mean, it makes sense that a tumor in the lymph node would provoke the immune system a little bit more, maybe, and therefore, like, start an immune response that then we could undo or, unveil with immunotherapy. So, the whole principle of all the immunotherapies we use right now is basically like the immune system was irritated by the cancer, and the cancer put up a shield to fight back, right? So we're not creating something out of nowhere. We're just letting the immune system do what it wanted to do. So what are those factors that led to the immune system being primed against the cancer? Well, it's smoking, neoantigens, maybe location of tumor too. But I don't think we fully know.
Joel, what does the separation of the curves look like in the adjuvant setting versus neoadjuvant? Is it significantly different in the ones where we have survival data?
Oh, that's a really good question. If we think about overall survival data right now, we have overall survival data for Checkmate 816, which is just the neoadjuvant, right? And about a 10% survival, separation of the curves. And then we also have Keynote 010, and that's about a 10% survival of the curves. Like your proportions analysis, like it might be 8 to 10% or 10 to 12% if you like forget about the 20% of patients that didn't go to surgery after a neoadjuvant study. But we also have people who might be getting immunotherapy afterward. And one of the slides that I took out in the interest of time is like long-term survival for stage 4 patients who had PD-L1 positive disease 5 years later. We see 15 to 20% of patients alive off treatment with only immunotherapy. So like, as great as it is to be getting it out with surgery and treating with the multidisciplinary approach, like we actually do see 15 to 20% cures or whatever is going on in the stage 4 setting. So, I think the survival curves on the tails, I'd have to bring up the slides again to review in detail, but I think they're relatively comparable for overall survival between 816 and
Yeah.
010, but remember 010 was PD-L1 1%, and 816 was actually all comers in that survival curve.
Okay.
So whether
Yeah.
there's a benefit in the
But I
PD-L1
think the
0 in
point
the
is,
neoadjuvant, I don't think
yeah,
we know, but it's hard to withhold.
it's hard to withhold.
It's hard to withhold immunotherapy.
Well,
Like,
yeah, but the
so
point
like
is,
in
I
the
think at a
neoadjuvant
certain,
setting, we're going to throw it all in. Like,
I don't think
Kiran's,
we have to feel too bad for these node-negative patients about not giving them induction therapy because the post-operative curves, the survival curves are pretty similar if they get adjuvant immunotherapy, chemoimmunotherapy.
correct,
Yes.
exactly. So I think,
Okay.
adjuvant may be able to rescue for neoadjuvant.
Yes.
And we don't really know what the role of continuation immunotherapy is after neoadjuvant right now.
Yeah. Um, how about another case? 5 centimeter left lower lobe hilar tumor in a healthy 71-year-old Asian woman, never smoked. Of course, you're checking mutation analysis, and she's got an EGFR exon 19 deletion.
I smelled it.
The tumor is, yes, we see a lot of that out here. The tumor is invading the main pulmonary artery, Kiran, over about 5 centimeter length. This is on the left side. There's one left paratracheal lymph node positive on PET, proven in mediastinoscopy. So, you've been using the term resectable. Is that resectable? And I think you made the point. Resectable kind of should mean, is resection the best thing for the patient in combination with other treatments, not just can it be removed? So is resection the best thing? Central tumor probably requires a pneumonectomy by extensive PA involvement, although you might go in with a thoracotomy and try to take things apart and put them back together. But 5 centimeters is a lot of invasion. And one positive node.
Yeah, so we're talking about T2B N1 or N2. We're saying it's N2 disease, single station N2.
Probably T3 single station N2. Yeah, requiring
Yeah.
pneumonectomy. Left pneumonectomy though, right? Not as bad as right pneumonectomy.
And it puts it into a stage 3A category where we know there's benefit to neoadjuvant chemoimmuno. I think I briefly mentioned in the discussion that you oftentimes want to make the surgical decision up front. Previously, we said with stage 3A patients, pneumonectomy just portends abysmal surgical risk and 30 and 90-day survival, and people, there's some places that would avoid doing pneumonectomies in these patients. But with these emerging immunotherapy trials, they've shown that you can do pneumonectomies in these patients with acceptable morbidity. So, I think
Especially left. Yeah.
Correct, exactly. So in a young, otherwise healthy patient who has a left-sided tumor that may require pneumonectomy, I would say I would treat neoadjuvantly and plan for surgical resection.
Okay, what's your
I'm gonna add a
neoadjuvant?
bit. I'm gonna add a bit of nuance. So, with the EGFR mutation, neoadjuvant, if I were asked to offer neoadjuvant, I would go chemo and osimertinib. So I'd use the EGFR TKI, which we have a little bit less data of promoting resectability and things like that. Personally, I'm going to say I haven't seen that much invasion from EGFR mutant lung cancer. Like, it just feels like it doesn't do that quite as much as other cancers. But what I do see is there's always more nodes positive than we think they're going to be. Like,
No, but this lady's had a mediastinoscopy. Every node was checked.
All right. Good.
Mediastinoscopy.
EBUS, EUS, mediastinoscopy, every single one. Yeah. I think this is a patient that if surgery were being considered and was feasible, especially with downstaging, we can put in quotes, that I'd feel comfortable adding chemotherapy and immunotherapy in the neoadjuvant setting. But I'll also make a plug
Really?
for there's neoadjuvant chemotherapy and osimertinib.
Yes.
We say immunotherapy too easily after this talk, don't we? So, but I'll also make a plug for just chemo and radiation. So we can give, carboplatin, pemetrexed, 6 weeks of chemo radiation, bathe the mediastinal nodes in the primary, and then we give osimertinib in that case forever, actually, based on the locally advanced Aura study. So
And in
we
2
never
years,
stop the osimertinib.
Kiran and I will be asked to take out her like dying bronchiectatic left lower lobe from the radiation after a
So
cure.
this
So
is one of the toughest cases, right?
yeah,
You know.
yeah.
But I think the Neoadora is not part of our standard of care with the neoadjuvant osimertinib, but I think it could be used in select circumstances to try and you know, minimize the risk of the patient honestly having metastatic disease. So that's the other thing we see sometimes in EGFR mutant lung cancer is it's a lot more places than we think it's going to be. So we've run clinical trials of neoadjuvant osimertinib in the chemoradiation setting, and we'll see bone mets turning sclerotic that we had no idea where they were on PET or on CT scan. So yeah, EGFR mutant lung cancer, I view like it's more of a systemic disease. So I tend to be a little more cautious about surgery.
So neoadjuvant osimertinib, we don't have survival data yet, correct? Just
Nope.
just event-free survival.
Response rates and barely event-free survival, only 15% of events have been reported. So
But
it's
25%,
very early.
but a 25% pathologic complete response.
Yeah.
Basically.
Yeah, with OC plus chemo,
Yeah.
which I think I'd advocate for more than just OC alone.
Because you think the chemo gives more longer-term benefit to the end of that tail, that survival tail maybe actually kills tumor as opposed to shrinking it?
Maybe, but if we're going in with neoadjuvant, why aren't we giving everything we have? You know, I'm perfectly comfortable with chemo and osimertinib in the stage 4 setting. And practically speaking, a lot of times we won't get the EGFR test for a couple of weeks until after we're like kind of making those decisions. So we can always start with chemotherapy and then add the OC to it. And I'm going to be giving OC afterward for 3 years, so I have no problem prescribing the OC and adding it in.
Okay. For both of you, should patients with 2 N2 nodal stations involved, but you know, not bulky, but resectable, clearly resectable N2 nodal disease, lobectomy possible? Should we be giving them induction and operating on them in most cases?
We have a whole new stage for this now, right? You know, this is like the new like N2B staging. Yeah, that
Yes.
you know, I will point out, and it's hard to get into the nuances of staging, but when we talk about all the adjuvant trials, those adjuvant trials have been conducted through multiple different staging systems. And like most of the adjuvant trials, both for the EGFR TKIs and for the immunotherapies, were done with the 7th edition staging criteria, and now we're on to the 9th, right? So I can only guess that the stage N2B, as opposed to just N2, is created for a reason, and that reason may be to ask this question. Kiran.
What do you think?
Yeah, I think it's potentially resectable. I think up to T3 tumor with non-bulky N2 disease, you know, this is perfect example for a multidisciplinary discussion, right? I think it's potentially resectable. I would discuss neoadjuvant treatment options, and depending on the location of the primary tumor, the number of nodes involved, where they're involved, I would consider it.
Yeah.
Somebody in the chat asked about KRAS mutations, specifically G12C, if we want to get to that.
Oh, I don't see the questions. You see a question?
Yeah, so I see Dr. Horowitz out there asked a question. Please speak to patients with KRAS mutations G12C. So KRAS G12C, we do have targeted therapies. They work for, you know, maybe 6 months in the metastatic setting, so they're not nearly as good as the immunotherapies that we see. So, you know, generally, KRAS G12C happens in the setting of a smoking history, happens for those patients who would benefit from immunotherapy. So as of right now, I would generally treat them as standard of care, exactly the same way that I would treat a smoking-associated lung cancer without a targetable alteration. However, I will note that there are clinical trials ongoing. We're just opening one at Stanford involving a KRAS G12C inhibitor added to the immunotherapy, both in the early stage setting and in the metastatic setting, to see if we can get some sort of synergy between immunotherapy and the targeted therapies in that setting. And it looks like some of the targeted therapies are compatible with immunotherapies. So I would recommend a clinical trial if you have a patient out there. There are clinical trials available for the adjuvant setting. Otherwise, I would treat with immunotherapy strategies. And surgical considerations, I assume, would be the same based on mutations.
Yeah. How do you guys make the decision about neoadjuvant only, perioperative? Can you change? You've decided you're going to give a patient perioperative. Obviously, if they're having bad side effects, you can change. How do you change based on the pathologic results from the resection?
It's more of a medical oncology question, right? So, if I've given neoadjuvant chemo and immunotherapy, then I get a pathologic result or not. And then after that, if I have a path CR, I may have a discussion with the patient and say, you maybe don't need any more than this. But at least in the US setting, if I've embarked on a regimen that's intended to be perioperative, and any of the approved drugs, durvalumab, pembrolizumab, or nivolumab can be used perioperative, even if you use them neoadjuvant. So I tend to continue, but I don't know if it does anything.
Do you think it does anything?
Hard to tell. That's a good setting for MRD
Yeah.
and doing circulating tumor DNA. And if we see evidence of cancer coming back, we need to intensify, and we have trials around that question.
Yeah.
It looks like we might be at time, per the
let me dig out one more question.
Bonus time.
Yeah, I think I've covered everything I wanted to hit on. So thank everybody very much for participating. I don't know how many of you were out there. There's probably a way I could tell that, but I don't see it. And I think we have some announcements from the STS before you log off. What do we have from the STS?
Thank you so much to our moderator and panelists for your participation and insight. And thank you to our sponsor, AstraZeneca. If you're not one already, we invite you to become a member of STS. You'll enjoy a variety of discounts, benefits, and opportunities to help you grow professionally. Learn more at sts.org/membership or scan the QR code on your screen. Registration is now open for STS 2026. Find more info on the calendar of events at sts.org. We hope to see you there. Mark your calendar for an upcoming STS webinar titled Optimal Outcomes in Acute Type A Aortic Dissection. Thank you to all attendees for joining us today. We appreciate your time and your engagement, and we hope you found this webinar valuable. Until next time, take care.
Thank you, gentlemen. Appreciate you helping out.